Good afternoon, everyone. My name is Adiba Kamarul-Zaman. I'm the President and Pro-Vice Chancellor of Monash University, Malaysia. And in this session, I'm also acting as the past president of the International AIDS Society and therefore the co-chair of this session on the IAS-Lancet Health and Human Rights report. So thank you very much for joining us in what we believe is a very important session that brings together many of the things that we've been discussing in the last 2 days in relation to global health, public health, inequities, and social justice that is so important for health. When Chris Byra, a fellow past president of the International AIDS Society, and I felt that we needed to do something in 2020 to commemorate 40 years of HIV/AIDS, we felt that the HIV movement has really been instrumental in bringing together the importance of human rights in ensuring health, not just for people living with HIV or people at risk of HIV in key populations at risk of HIV, but also for health in general. We set about to bring a group of people together, not just those working in HIV, but also human rights experts, and also others who could inform the work that we wanted to do to look into what is happening in the field of health and human rights and come up with some recommendations to advance the cause. Of course, for those of you who work in infectious diseases and HIV/AIDS, you know that at the very beginning of the pandemic, it became very clear that unless we centered human rights in the response, we centered it not just in evidence, but also in human rights, in everything that we do to respond to the HIV pandemic, we will not get it right. And the lessons learned from the last 4 decades have been important in other aspects of health and global health and public health, of course. But little did we know when we started this project in 2020 that there was going to be another pandemic, namely the COVID pandemic, that really amplified the need to respect human rights, given the inequities that drove the risks for contracting COVID-19, but also eventually, of course, what we all know in terms of the inequities with vaccine delivery. A lesson we didn't learn from HIV pandemic when we had the stark difference in terms of antiretroviral coverage in the very early stages when antiretrovirals were discovered. And then, of course, the situation, the challenges have gotten even greater in the 4 years, culminating in the launch on March 25th, with conflicts in many parts of the world, worsening climate crises, etc. So what we hope to share with you in the next hour and a half is a launch, some excerpts of a launch that was done on March 25th with colleagues from the Lancet, including Richard Horton, the editor-in-chief, and Pam Das, and my fellow co-chair, Chris Byra from Duke University, who cannot be here today. But we will share his thoughts at the launch. And we have a superb lineup of speakers, including Professor James Ward, our current president of the International AIDS Society, Sharon Lewin, will lead a panel discussion. And of course, my fellow commissioner, Lucy Stackpool-Moore, who together with Dr. Jonathan just done a fabulous session with the community a short while ago. And Lucy is also going to share the recommendations that have come about from this commission. Aside from HIV/AIDS and sexual health and reproductive rights, the group decided to look deeply into seven other areas that really highlight the challenges that we face in the domain of health and human rights, and that being pandemics and access to products and medical equipment, etc., to do with pandemics. We also, now let me move this, I've somehow lost my glasses and I can't see. I'll just move to the domains that we decided to examine, which the worsening climate crisis, conflict and its resultant displacement, migration, and refugees. You'll hear a wonderful videotape from Lorraine Dean, one of the commissioners, on the impact of racism on health and human rights. As mentioned, sexual and reproductive rights and health. Once again, COVID, I think, amplified the negative impact of social media, particularly in relation to misinformation and disinformation and the right to science. And finally, at the very, very last minute of us putting together this report, Richard Horton requested that we add artificial intelligence to the report as well. One of the things, and economic and commercial determinants of the right to health. One of the things that you will hear later on in terms of the recommendations is, what does it mean to us as health professionals? I think for many of us, human rights can be a very abstract thing, and the focus, naturally, because the Lancet is a journal for health professionals, we wanted to make our recommendations more concrete and something that all of you can take and hopefully practice in your day-to-day lives, either as healthcare professionals in terms of health service delivery, as advocates, as teachers. And the other message that we hope that this report brings is that not just health and human rights is central to what we do, but really if you examine those 8 domains that we chose to study, and particularly in the context of the climate crises, the conflicts that are around us, that unless we center human rights into everything that we do, we are as humanity, in fact, our very own survival is being threatened by all these challenges that we have around us, and hence the importance of centering not just health and human rights, but for very survival and dignity of us as human beings. So with that, it gives me great pleasure to share with you some excerpts from the launch from March 25th.
Part of the difficulty, I think, is that for some, human rights are seen as a kind of unattainable set of goals, even utopian goals, that are judged meaningless in the rough world of realpolitik. But as this commission shows, compellingly and convincingly, nothing could be further from the truth. And let me take one example, and that is the right to the highest attainable standard of health. I would encourage everybody to read a document that doesn't sound very exciting, but is of profound importance to our work in the health community. And that is General Comment 14 from the Committee on Economic, Social and Cultural Rights. It was published in 2000, and it set out the meaning of the right to health very clearly and very pragmatically. When we talk about the right to health, we don't mean the right to be healthy. When we talk about the right to health, we're not talking about some perfect utopia. We're talking about considering health in the context of a state's available resources. But the right to health includes not only the right to health care, but also extends to addressing the social determinants of health. General Comment 14 famously set out its AAAQ definition, the progressive realization of the availability, accessibility, acceptability, and quality of healthcare services. And it went on to state, incredibly important this, that a human rights-based approach to health demands non-discrimination and equal treatment, a gender-based approach to health, recognizing the different biological and social determinants of men's and women's health, and provided specific protections for children, adolescents, older persons, persons with disabilities, and indigenous peoples. But it went further than that still. General Comment 14 imposed obligations on governments to progressively realize these objectives. And so a human rights-based approach provides not just a framework for thinking about action, but also a framework for accountability, holding those with power accountable for their promises and their commitments. So let me reiterate, this commission could not be more timely, because look at the world we are in today. As a human-created famine threatens to engulf several million people in Gaza, as conflicts and violence in Sudan, Myanmar, Ukraine, Ethiopia, the Sahel, and Haiti destroy lives and livelihoods of millions of people, and as political leaders, governments, and even courts worldwide are rolling back long-held rights of some of the most vulnerable, oppressed, and silenced groups in our society. So now is a moment to insist on the centrality of human rights, not only in health or global health, but also as a fundamental guiding set of principles for domestic and foreign policy, of which health forms such a substantial part.
We've been working for close to 4 years now, and this really began with scoping reviews, with looking at what was currently in the literature, with developing themes, and then working as teams on specific areas. And one of the things I think that has really made this such exciting and hopefully impactful work is that this is a truly interdisciplinary team. We have people from medicine, from mental health, from history, from human rights and law, from environmental law, from across multiple continents, from low and middle-income countries, upper income countries, and of course we have some spectacular modelers. I'm going to show you some of their work in a moment, in which we used mathematical modeling to really interrogate some of these critical interactions of health and human rights. So a few brief framing remarks. First of all, just last year, the Universal Declaration of Human Rights turned 75. So we are now 76 years into this era. And as Richard highlighted, the use of the human rights paradigm, the human rights approach to health has really led to some spectacular outcomes. And perhaps now is carried most fully forward by the movement for universal health coverage. But while we were working on what would have been a Universal Declaration of Human Rights at 75 kind of report, the COVID-19 pandemic swept our world. And we very quickly saw starting with PPE and oxygen, some of the most basic aspects of care before we had vaccines and antivirals. Really how little equity, justice, and the right to health played out in the distribution. What really played out was wealth, where countries had the manufacturing and the capacity, and there were country after country where simple things like putting someone on oxygen going into respiratory failure was impossible. And we saw, unfortunately, rather than global solidarity in the face of the pandemic, nationalism, closing borders, anti-immigrant sentiment, and a plethora of disinformation and misinformation. We also understood, and this of course is emerging as one of the great new challenges in global health, that the climate crisis is inescapable in thinking about the future of human health and indeed the health of all living things on the planet. But that here too there is a rights and social justice aspect, because the health impacts are being felt most powerfully by the people who did the least to contribute to the climate crisis, many of whom have contributed almost nothing to the climate crisis, and yet they are paying the highest price. And that is an issue that we're going to have to address. Impunity for rights violations has become a new norm of war. And what we have seen, and the report really highlights, is a fundamental series of threats to the principle of medical neutrality, to the idea the sick and the wounded, women in labor, children, the elderly, deserve special protection in conflict. Instead, what we've seen is widespread use of attacks on healthcare facilities, healthcare providers, even on ambulances, as a tool of terror and as a tool of harm. And finally, we are in a period where the human rights consensus is being threatened by rising racism, by xenophobia, by anti-immigrant policies, and that all of these together threaten the human rights consensus and undermine all of our right to health. So that is where we began, looking at the problems. And then we asked ourselves 3 questions. These are the framing questions. So given what's happening in the world, what is the future of the health and human rights movement? How can the health and human rights framework be revitalized and reinvigorated to achieve the healthy communities we all want to see? And finally, what domains of the health and human rights framework are most relevant for ensuring robust health systems and universal access to care?
We will have 3 commentators. We'll have Slim Abdul Karim, who's from South Africa, but he's currently joining us from the US. Rajat Khosla, who's at the University of Malaysia, and Parvin Palmer, who's from California in the US. Now, each of them have different day jobs and are sort of coming at this report from their perspective and some of their experiences that they've encountered over the last few years. So if I could just hand over to, let's say, the first person I can see here is Parvi. Over to you. Thanks.
Sure. Thank you so much, Pam. And thank you to the Commission for putting together this incredible report. It is really remarkable, the breadth of this work and the thoughtfulness of this work. And so I just really greatly appreciate this coming out, and certainly couldn't be more timely, as Chris said. So many of these issues have really become critically important, particularly given the breadth of conflict and displacement and human rights violations in so many contexts, and specifically within the context of the pandemic. I think for me, one thing that I've been doing reading this report and listening to this presentation is thinking about the reactions of those that we work with, those that we advocate for as human rights activists and health providers. So the patients here in Los Angeles, the people that we've worked with, that I've worked with in, displaced by conflict, in a variety of settings, those that are detained in ICE detention facilities across the United States, immigrants that are detained in the U.S. For seeking asylum, often which is of course a guaranteed right under international law. And a couple of things come to mind. The first is that I really appreciate that this report highlights that these principles cannot be acted on in isolation. That this is something that has to involve a broad team of, engagement with policymakers, economists, activists, and I think centrally community as well. And this is something that as health providers, we strive to do, and I think, really could certainly do better, kind of broadly. And I think, human rights has always been, the language of human rights is something that is so critically important. But I think it's one that we as a community could do a better job of making relevant and understandable to people from different communities. And so that's something that I would really love to hear a little bit more about thoughts on that from my colleagues as well. Human rights frameworks are kind of distant in some ways, but really should be a part of our human language. No matter who you are and where you're from, it should be something that you're sort of well aware of these rights and how they apply to you.
Okay, so that's sharing some thoughts from our panelists that we had on the launch that was done on March 25th. But now it gives me great pleasure to invite my fellow commissioner, Lucy Stackpool-Moore, who's the founder of WATIPA, a social enterprise, to share with you the recommendations that have come out from this report. Lucy?
Ooh, tech, there we go. Hi everybody, thank you for joining us today. I'm just going to learn how to move this along. Adiba, was there a clicker or did you? Oh, yeah, got it. Green one, the very large green button here, that's very wonderful. So thanks very much for joining us. I'd like to begin by acknowledging the elders and past, present and emerging of the Kulin Nation where we meet today and pay my respects to everybody and extend those respects to Indigenous members of the audience today and to everyone for joining us. It's been very moving and I know it's an ongoing conversation, but really considering these questions in relation to some of our panel in terms of Indigenous health, very pressing in Australia and around the world, and also learning about Indigenous ways of knowing and being and how we can understand that and how someone like me can better understand that in the context of the language of human rights is a very interesting conversation. So I'd like to start with that. I'd also like to acknowledge communities. This is something from QPP, which is Queensland Positive People, the regional network of people living with HIV in Queensland, who have a beautiful phrase to acknowledge people living with HIV involved in their work, both those who've passed and also those current. And for myself, my own research and program leadership and advocacy has been very much grounded in the HIV response in Australia and globally, so I'd like to also acknowledge the people living with HIV who've generously shared their stories with me in my research and also in my work. It's been extremely informative and it often comes with generosity of time and openness and trust from those communities. So this panel, a couple of remarks and then a panel discussion today is really framed around action. What we'd really like to do is help connect the global conversation, the recommendations from the Commission on Health and Human Rights with action, the sort of so what factor that goes with all of this after 4 terrific years of interesting conversations, an interesting report that can be improved and critiqued ad nauseum, but really a tool is only as good as what it's able to achieve in practice, or that's my view. So we're hoping that from this discussion today and going forward, we can help really use the work of the Commission and its recommendations as a tool to promote health equity in different contexts around the world. Just to begin, though, I don't assume that we all share my understanding of human rights, and these aren't definitely the only understanding of human rights, but I did want to ground what I'm going to say in this notion, because for me there's 3 very different but not mutually exclusive ways of understanding human rights that is very much shaped how I engage with the Commission and how how I'm here today. So the first one is very simple in its concept, not in reality, but this idea that just by being human, one is born with equal and universal human rights. So this is from the ancient philosophers of John Locke, this notion of natural rights, and there's a whole set of scholarship in that area. The second one, which is more or less how Richard Horton was speaking about the human right to the highest attainable health in the film just now, is this idea of the sort of the legal definition or the codification of rights in laws and policies, the obligation of states as duty bearers to govern in a way that can respect, protect and fulfil rights. So Richard Horton mentioned the International Convention on Economic, Social and Cultural Rights. He mentioned Article 14. You also have scholars and fellow Commissioner Sophia Gruskin and others who very much define rights in terms of laws and policies. Alan Maleche is another one from Kenya, fellow commissioner. You have some constitutions around the world who are very rights enabling and rights affirming. Unfortunately not yet in Australia, but some good examples of this is South Africa, Germany, and to a less extent Malawi. And I'm going to come back to the South African Constitution in a moment. And the third one, this is perhaps a little different, and certainly on occasion I've had the opportunity to teach at the University of Melbourne in the law school and also in London, and this is often very surprising for scholars in law to understand rights from this perspective, this notion of rights from below, as it's been the term used by John Ife, or John Ife, I'm not sure how to pronounce that, an Australian scholar, but this idea that rights are realised through this constant process of negotiation, and that people have an intrinsic sense of their entitlements and their rights, particularly when they're violated, and that rights are actually defined and realised through those struggles to protect and enable and to realise those rights. So it's very much this notion about understanding rights from those daily struggles that are grounded in human agency within the context of this sort of push and pull and the dynamic notions of society. There's a Kenyan scholar, Celestine Nyamu Musembi, who's written very eloquently on this, and it's also as a principle of Ubuntu, as an indigenous sort of notion, philosophy from Southern Africa that does underpin the South African Constitution, and at one point was explicitly named in that Constitution. I think in the final draft it might still exist in a footnote, but it's this idea that Ubuntu has many different meanings, but I think one that is the simplest to paraphrase is this idea that I am who I am because of you, and this notion of rights is intrinsic with responsibilities and this reciprocity between self and society. I think that's really important in understanding who are rights bearers and who are rights holders and who are duty bearers, because often those individuals at the centre of all of this are the one and the same person, even if that person is the Prime Minister. Right. Next one is also just to ground this in an understanding of health. I think one of the things that can often be not a strong foundation for thinking about health is that the norm is the healthy person who's 100% physically, mentally able 100% of their lives, and that just simply isn't true. For every single person in this room, we have moments of health, we have moments of ill health. Some of us live with chronic conditions, some of us live with different things that limit our physical and mental abilities constantly or at several key moments throughout our life. So I think it's really important to also consider all of this within this dynamic and evolving kind of a life course approach to understanding health and how that can ebb and flow with the realities of life. And then connecting what does that mean at the individual level and that moment of ill health or great health and well-being in the context of a society and in a national context or a global society, and that interrelationship between the person and the collective. So coming on now to a couple of recommendations from the Commission. I would encourage everybody to read the full report. I'm not going to talk about all the recommendations here today, just pull out a couple to focus on. But really, probably obviously, one of the strongest recommendations is that we really need to recentre human rights for the achievement of health and wellbeing for all. That includes within the health field, but also as the health sector as a leader across other sectors, and to ensure equitable representation from different regions and different contexts and communities and different stakeholders to help improve the health response to recentering human rights. Really critically, and I'm going to come back to this in a bit more detail in a minute, is and as Adiba said at the opening, often the health workforce might not think of ourselves or themselves as leaders in health and human rights and as advocates and champions and enablers of human rights, but that couldn't be further from the truth. And so really looking at how for example, in medical education, in formative stages, as well as in service, how the language of rights or the practices of good quality and ensuring quality provision of services can be framed in rights language and can enable rights in that facility and sort of broader systems level, and looking at how the health sector can better measure the reduction and contribute towards a reduction in health inequity, to engage across all the different social determinants of health and actively combat disinformation and misinformation. In terms of local coalitions, this is really obvious and looking so important in connecting the global leadership in this area with local innovation and leadership, and looking across mutually reinforcing but diverse expertise and skill sets and communities leading to combat racism or gender inequity or criminalisation and other things that are disenabling rights in different specific aspects of people's lives. And really importantly, the flip side of that, to look at how safe spaces and welcoming spaces can be provided for all to enable human rights and health. And in a similar line, looking how all of these movements, not to be oversimplified or generalised or homogenised, but really how stronger together on some key messages can actually be very powerful and hopefully unavoidable for triggering action, whether that's local action, national government action or global attention. And significantly, as part of that, looking to build allies and address the commercial determinants of health in a way that is enabling of rights and affirming of rights, but also to seek some allies where that leadership does already exist within corporates. Just my second to last slide is really giving a more practical example from some other work I'm involved in at the moment with the World Health Organization, which has really taken that socio-ecological model that Adiba presented just now, that has emerged from the Commission report, but really turned it into a focus specifically for health and specifically around ensuring good quality healthcare by reducing HIV-related stigma. And the reason why, as an aside, I mentioned a lot of my work has been in the context of HIV and particularly in trying to combat and reduce stigma. And about 18 months ago was the first global day in July to pay attention to HIV stigma around the world. And on the one hand, that's fantastic. It needs attention. It's still a pervasive, pernicious problem. However, it's 40 plus years into the HIV response, we've known that stigma is an issue from the very beginning. And for me, I was actually really flabbergasted that we still need to have this day. I was annoyed and I felt actually very inadequate in terms of my own contribution to stopping stigma, to ensuring that something is done. We've been talking about getting to scale and addressing stigma. It's embedded in different funding policies. It's there in national policies. And yet, in terms of people's everyday lives, whether that's stigma around HIV or stigma around sexual orientation or gender identity, or race or gender inequity, it still persists, and that's because it's not in everybody's interest to get rid of stigma, but it absolutely must happen to enable human right to health for everyone and to have good quality healthcare. So beyond that rant, I was like, what can we do about it? Actually, maybe to really get to scale or really ensure that we achieve some gains in this space, and we're not still talking about this in another 40 years, we actually need to make it simpler and clearer to state the solution that we're trying to achieve. So really excitingly, the World Health Organization is leading in this and has this forthcoming technical brief that isn't focusing on stigma, whilst that's extremely important. It's focusing on how can we ensure quality healthcare by reducing stigma, by enabling diversity, equity and inclusion in the health workforce. And just by articulating more clearly the vision and the solution that we want to achieve in that space, hopefully it will become more actionable and more practical to achieve that. So this model here is essentially an attempt to combine the model from the Commission's report with the definitions around the actionable drivers of stigma and how we can look at taking a person-centred approach here, looking at the very centre of the circle. Up there on the screen is hearts. Obviously, people are complex human beings that give and deserve love and respect, dignity and inclusion. But looking at how that's not only the individual, but it's also a dynamic interplay with societies, with relationships, communities, and that combination of the personal and interpersonal shows that dynamic relationship there. It's also couched within a focus on rights, and in the context of health and the healthcare workforce, the language around universal health coverage and the right to the highest attainable standard of health. These are all clear ways where health and human rights have been defined and signed on to at a global and national level in different documents and covenants that already exist, so really hooking in with the language that has already been committed to and agreed by states. Then quite practically looking at the institutional, organisational, facility level, how can facilities be more enabling both for the providers and the workforce who are there, and really acting on having an inclusive workplace culture, one that is non-hierarchical and respectful and includes a diverse health workforce that is respected there and reflected, but also how can that culture of the workplace at the facility level help to translate into the actions and the health enabling and rights enabling ways that those providers deliver services. And then again, looking at how laws and policies can enable that, and more broadly, the international agreements and that sort of macro level global determinants of health there. So this is forthcoming in July, hopefully this year, having a very clear actions around ensuring people at the centre and what that means for the second priority around improving quality care, and then thirdly, what practically can be done in that policy and environmental level to help enable that to really make health and human rights a reality in skilling up the healthcare workforce to provide quality healthcare and reduce HIV-related stigma. So lastly, just to help frame some thinking for the other contributions from the panel and also the other speakers is really coming back to this notion of the report and the recommendations from the Commission, and is it a tool that's only as useful as how we're going to use it? So how can it be used to strengthen local efforts, and equally how can it be improved and be even more effective from understanding and responding to local efforts and amplifying local innovations? We heard just at the end of the recording from Paveen about the language of rights, and at times that could be disenabling, at other times it's enabling, so better understanding how we can communicate these things in the most effective way to achieve health equity. And this idea of how could we talk about it in a different way to be even more effective of that. So thank you very much. I think I'm now going to hand over to Professor Laurie Dean from, it's a pre-recorded message, she's joining us in the middle of the night, her time, from Baltimore, Johns Hopkins University. So there's a short film where she'll be going into a bit more depth from the Commission's work on structural racism. Thank you. Is there a way we could play the video, please?
I'm Laurie Dean.
Yep, thank you.
Associate Professor of Epidemiology at Johns Hopkins Bloomberg School of Public Health. And I'd like to thank the conference chairs and organizers for having me today. Today I'm going to be presenting a reprise of a presentation from a talk that was originally presented at the International AIDS Society Conference in 2023 titled Racism, Structural Inequity, and HIV. This work was co-developed by several contributors, including myself, as well as Dr. Harriet Deacon from the University of Cape Town, Dr. Javier Cepeda, also at Johns Hopkins Bloomberg School of Public Health, and Dr. Joe Ammon at the Dornsife School of Public Health at Drexel University. None of us have relevant disclosures. In 2022, the UN Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health issued a report on racism and the right to health. This report highlights that racism and discrimination are not just individual level events. Racism and inequity are also structural and implicate entire systems, nations, policies, and institutions that, in the totality of their effects, oppress or devalue people, and that also result in disparities in communicable diseases, things like HIV. We applaud her work and the acknowledgments that were made about racism's contributions to the right to health, but we also recognize that that work, that most recent work, builds on commitments that date as far back as the 1960s, 70s, and further. In fact, there are already several international covenants that establish the individual's right to health without discrimination as an immediate obligation of governments. These covenants specifically prohibit discrimination based on things like race, ethnicity, sex, gender, sexual identity, language, religion, political or other opinion, national social origin, property, birth, or other status. The grouping of all of these distinct parts of identity and elements of life highlight that protecting human rights requires attention to how, even within one single person, they can be associated with multiple categories or identities all at once. And it also reminds us that if we are going to deal with things like racism, we simultaneously need to also address other forms of oppression and inequities like sexism, homophobia, xenophobia, other forms of oppression, and do that all at the same time, if we want people to be truly free and optimally healthy. So there are many examples of racism and discrimination in the world, and I won't go through a lot of specific examples of racism and discrimination because I only have a few minutes in this time. But I'd say we see them in the media and we experience them in our bodies, and sometimes we even see them in the cover-ups that occur that are trying to absolve people in countries from accountability from these forms of oppression. In some places, discrimination is so pervasive and embedded in social institutions that it serves as a basic organizing principle of national life. And we know that has impacts on health and health equity. However, I'll mention that many of these share some common mechanisms. When I say these, I'm talking about incarceration, police brutality, health and social services, transportation, violence, housing, oppression, childcare, poverty, and other social determinants of health that have direct implications for HIV and that are then reflected in higher HIV rates when we see disparities and inequities in these social determinants. Removing racism and other forms of inequity requires addressing these social disparities and disparities in these determinants of health, with particularly a lens of equity, and also seeing them as part of protecting people's fundamental rights. We also need to address multiple of these factors at the same time, and that requires working both in health and in non-health institutions. Forms of structural oppression happen in every country. Yet we have no international standards or metrics for whether or not we're addressing or reducing racism, inequity, or discrimination globally. In fact, some countries don't even collect race or ethnicity data administratively, which makes this especially difficult to track or challenge. Both of these things make it difficult to show progress on reducing oppression across nations. And for far too long, governments have appropriated human rights to call out other countries while turning a blind eye to the inward work that they need to do in their own countries. For example, despite that in my home country of the US, our government has a history of condemning apartheid in South Africa that have limited Black South Africans, as you can see a picture on the left. Our same US government fails to acknowledge and condemn our own contemporary apartheid systems that limit optimal health and opportunity for Black Americans. And yes, resolving structural racism, oppression, and inequity is possible. We've already found ways to help protect people from HIV-related discrimination. In fact, according to country reports to UNAIDS, more than 70 countries already have mechanisms in place for reporting and addressing human rights violations against people living with HIV, as well as marginalized populations, although we'd also say awareness of these mechanisms remains insufficient. But it also reminds us that if we can resolve HIV-related discrimination, and if we can address that, we can also resolve and address other forms of discrimination, racial oppression, as well as other things. So while we continue that work on HIV-related discrimination, we also need to embrace addressing racism and discrimination in every other form. It also reminds us that structural problems require structural solutions. So I'm going to use some of my time to share some of the promising examples that have tried to address this and highlight some successful examples of how this has come together with health. One example is that in 2014, the Caribbean community, also known as CARICOM, adopted a 10-point plan for reparatory justice. And this plan highlights the need for European countries to acknowledge and apologize for historic racial injustices that emerged out of slavery and colonialism, but then also highlights the need for reparations to address contemporary human rights violations, socioeconomic deprivation, and health inequities, including things like high levels of hypertension and diabetes caused by these histories. These reparations are seen as a way of achieving structural justice if they are linked to addressing contemporary structural injustice that arise from those past and ongoing harms. This CARICOM campaign is exploring the use of reparation payments to redress harms due to a history of slavery and poor health outcomes today, as well as problems that around providing sufficient health care and other services in the affected countries. This idea is gaining momentum, and in fact, in places like Grenada and Botswana, they've also joined in on this, and other countries are looking to this group as a model for how reparatory justice is tied to better health. In Costa Rica, Cuba, Ghana, Turkey, and Thailand, they've worked to develop health systems that address underlying social, economic, and political causes of poor health. Since the 1990s, Costa Rica has restructured its public health system around multidisciplinary teams of public health providers who work with local communities to identify needs and priorities in specific geographic locations. And then they apply a health equity lens to deliver a full range of curative and preventive services. This is a program called EBAIS, or you might hear the term the EBAIS model. Before 1990, before this program was implemented, only 25% of Costa Ricans had access to primary health care. But from 1995 to 2001, the number of EBAIS teams increased from 0 to 737 clinics across the country, covering 80% of the population and giving them access to primary health care. While still 295 fewer clinics than needed for full coverage, by 2017, over 93% of the population had access to primary health care. Challenges withstanding, the restructuring in Costa Rica has achieved dramatic improvements in healthcare outcomes and reduced inequalities in access. And this is just one example that has been applied in these places, and that could be applied in other places if we have this health equity lens. We'd also say that solutions to public health problems are not always public health solutions. And structural problems require structural non-health solutions. As a final example for this presentation, we point to Proyecto Escudo, which means Project Shield in Spanish. We feel like this is a good example of addressing multiple social factors and working in a non-health institution, in this case, working with the criminal justice system. This particular program addresses police violence, incarceration, and discrimination, all of which are associated with HIV cases among people who inject drugs. So this program has focused on training police officers in Mexico in harm reduction, decriminalization of drug offenses, and occupational safety, and how to avert accidental needle stick injuries, as well as basic HIV epidemiology. After that, they modeled the impact of this program, as well as the cost effectiveness on HIV among people who inject drugs. And they found that in the 2 years after Escudo was implemented, 1.7% of new HIV cases had been averted. When they projected that over a case of 10 years, if that effect were maintained with retraining, Escudo could prevent 4% of new HIV cases. And in a separate analysis, they found that this program was cost-effective due to its dramatic reduction in incarceration costs. These examples certainly give us hope, and we know that there's still other work to be done. In our recently published paper in The Lancet, we outline a few recommendations for nations, the World Health Organization, and the healthcare community of how to address structural inequity in health as part of human rights. I'll just highlight 3 here. The first one is that no change happens without resources. So we need to provide fiscal support based on restorative justice to redress the impact of structural inequity on health. And this could come in the form of reparations as well as other means to redress the long-term impact of structural inequity based on past harms. We could also establish some international standards to assess progress on reducing racism and discrimination as fundamental causes of health inequities. That is to say that standards can help us bring accountability, and we can use the reduction in health inequities as our barometer for both health and social progress. Thirdly, now that the WHO or the World Health Organization, that it's been agreed that they can serve as a treaty body, we believe that the World Health Organization should develop a treaty that protects the right to health, free from oppression, as a human right. A full embrace of establishing health as fundamental to human rights must recognize a need to address discrimination, structural barriers to health, and other forms of oppression for groups who are devalued or marginalized, the progress of which we can then measure through the reduction in health disparities and the achievement of health equity. Thank you.
It now gives me great pleasure to invite Professor James Ward, who is a Pinjanjara Nukunu man and an infectious disease epidemiologist and a national leader in Aboriginal and Torres Strait Islander research from the University of Queensland, and he is going to share with us what this report means to close the gap for Indigenous health in Australia.
Thank you. Thanks very much, Adiba, and thank you to the organisers for the invitation to speak here today. Let me begin by paying my respects to the Bunurong and Wurrung elders and their descendants for welcoming us here this week, but also for continuing to maintain traditions, country, customs and knowledges in this rapidly evolving world we live in today. My task here today is to frame the IAS-Lancet Commission with an Indigenous lens. And a couple of disclaimers before I start. I'm not talking on behalf of other Indigenous groups or peoples, but rather share my personal reflections on this report. And second, I can't do justice to all 8 issues in the small amount of time I've got here this afternoon. So I want to begin by saying that one of the resounding messages in the report is that health and human rights agendas globally have deteriorated over the last 4 to 5 decades. And as sad as it is, it's a position that resonates with many of us in this room here today. The report outlines some of the major challenges, many of which are of ultra importance to our people around the globe. I also want to say that Indigenous health is inextricably linked to colonisation, and colonisation is inextricably linked to human rights, or violation of human rights, should I say. So I want to start by going back a step or two on the issue of health and human rights for Indigenous peoples here in this country. And first and foremost, and maybe a little provocatively, say that one of the biggest health and human rights issues facing us in this country is our failure as a nation to have not yet come to terms with fully reconciling with First Nations peoples in this country and pushing forward on fundamental human rights principles such as voice, truth and treaty. The failure of last year to get up a fairly simple proposition that would have enabled our peoples to have a seat at the table, enshrined in the Constitution, is so telling of where we are at present in regards to health and human rights. The no result is a combination of the 8 issues outlined in this report: economic and political determinants of health, misinformation, trust, the use of AI throughout the campaign. In relation to health and human rights, the concept of truth, treaty and voice underscores the importance of acknowledging the historical and contemporary injustices and addressing the root causes of health disparities, upholding the rights of our peoples to access culturally appropriate healthcare services, and maintaining control over our own health, and the empowering of individuals and communities to advocate for our health rights and participate in decision-making processes that affect us. Embracing these principles of truth, treaty and voice should have and could have advanced health equity and in promoting human rights for all of us. Instead, we regressed. The denial of these principles are, of course, misaligned and in contravention to the rights of Indigenous peoples as enshrined in the United Nations Declaration on the Rights of Indigenous Peoples. So to the task at hand today, and to the first of the 8 challenges that have been laid out in the report in relation to health and human rights for Indigenous peoples. Firstly, pandemics. There is no doubt that Indigenous peoples globally didn't fare well in the COVID-19 pandemic, often without representation to pandemic responses, often left last to respond, often locked out of initiatives. This resulted in overrepresentation of cases, the severity of cases, in overrepresentation of mortality data, as well as lower vaccination uptake. The disruption of cultural and economic activities that accompanied the pandemic crisis endangered the survival of many Indigenous communities around the world. The Office of the High Commissioner of Human Rights observed in 2020 that many states were failing to adopt specific policies and at times neglecting even to include Indigenous peoples in general COVID-19 responses. Here in Australia, we had a little bit of a different story. We had enough corporate memory in Australia from the H1N1 pandemic, and we put in very good pandemic governance mechanisms early. Our Aboriginal and Torres Strait Islander community, particularly the community-controlled health services sector, mobilised quickly and through leadership from Nacho set about quickly to put in place structures, systems that influence policy and programming throughout the pandemic. There is no doubt we saved hundreds of lives, if not thousands, and we had modelling to show that if COVID was to run rampant in just a few of our remote communities. Our response was transformational in the way that government and community work together. Our lesson for future pandemics is to ensure we have a voice at the table, the right tables, and we are first at the table. It's a health and human right. Of course, we've still got much more to digest about the pandemic and much more to think about over the next little while, including sharpening our responses for the next. The second challenge outlined in the Commission is climate change, and rightly so. Indigenous peoples are identified as a priority population. And this is why. Health to us is country, and country to us is health. And having access to health and country is a human right. Many of our communities rely on traditional lands for sustenance, cultural practices, storytelling, well-being, and environmental degradation, such as we saw in the middle of COVID-19 with the destruction of the Juukan Gorge by colonial mining giant Rio Tinto that destroyed intangible and tangible aspects of the whole body of cultural practices, resources and knowledge systems of human life going back 46,000 years. There's a saying in Indigenous health, when one of us loses, we all lose. When one of us wins, we all win. This catastrophe and other major environmental events caused by climate change will continue to have severe health and wellbeing impacts on our people and communities. Rising sea levels and temperatures means people's livelihoods and knowledges will be destroyed on our island nations. Our deserts become hotter, means urbanisation will occur faster, and deforestation means all of our flora and fauna are at risk and our knowledges will be gone forever. This threatens all of our food and economic security. And it creates a new problem, the urbanisation of our people, which I might say is already occurring, as you can see here. Our capital city populations have grown by 41% over the last 20 years, and even greater for some of our cities over the last 10 years, where both Naarm here and Meanjin, where our mob have grown, the population has grown 80% in both of those cities, which already puts additional strains on existing services for our mob. Most likely those who move to the cities will be market forced to the fringes of major cities, where they will likely experience more severe weather events, experience poorer air quality, experience more overcrowding, and face increased risk of adverse health outcomes. An urgent priority for all of us should be the development of a national agreement on climate change action focused on Indigenous communities, and central to that has to be the deployment of rangers who know how to scale up and practice Indigenous knowledges that we've always had about caring for country. The third issue, as we've just heard from the report, is structural racism, discrimination and inequity. Again, these themes are directly linked to the United Nations Declaration of the Rights of Indigenous People that states Indigenous peoples have inherent rights, including the right to freedom and equality without discrimination. It is truth, it is unjust, but it's a reality that for many Indigenous peoples in this country, they are turned away from healthcare systems and they end up in coronial reporting systems instead because of racism and discrimination. Whether it be the case of Miss Williams, who presented at the local hospital in New South Wales 18 times in 7 months because her pregnancy had been identified as high risk. But it was when Miss Williams, who was 6 months pregnant at the time, presented to the emergency department in the early hours of New Year's Day 2016, and nurses gave her paracetamol and allowed her to go home after 34 minutes. Her condition worsened, and 15 hours later, she died from bacterial infection, meningococcal, and blood poisoning, sepsis. or whether it be the Four Corners investigation of the Doomadgee Hospital that highlighted the systemic and institutional racism in the deaths of 3 young women who had all been diagnosed with rheumatic heart disease and turned away with paracetamol. It's also true and abhorrent that many of our people end up dying in prison and police custody, and highlighting the recent stories of Miss Tanya Day here in Naarm, Mr Jai Wright in Sydney, and Mr Kumanjay Walker in Yuendamu. We have much to do to ameliorate racism in Australia. This racism is currently being enabled by our leaders, our public commentators, big business and media. We have no national reporting system of racism in healthcare in this country or other agencies, at the structural level, at the interpersonal level or personal level. We require major reform in the form of widespread anti-racism strategy and policy to get our human rights and health aligned. The 4th issue identified in this report is sexual and reproductive health rights. And let me tell you, there is nothing right about the ongoing STI pandemic occurring among young Aboriginal and Torres Strait Islander people across this country. It is not acceptable that 1 in 4 or 1 in 5 young people across many of our communities are diagnosed with either chlamydia, gonorrhea, trichomonas or syphilis every year. It is also unacceptable that we cannot quantify the impact that these recurrent infections have on sexual and reproductive health outcomes for young women in these communities. It is also unacceptable to be shot down if you frame these STIs as a violation of human rights. If anything, we require a major inquiry to assess impact on the reproductive health outcomes for young Aboriginal and Torres Strait Islander women particularly. The 5th issue I want to talk to this afternoon is trust, mistrust, information and misinformation. In this post-pandemic period, we've seen health misinformation proliferate. We have seen trust in governments and corporations decline about all sorts of things, vaccination, about policy and programs. And Indigenous peoples used to have one of the highest vaccination rates for our children. It's currently lapsed and we're falling behind, greater than we've ever been before over the last 2 decades. But it hasn't only been COVID that's created this scenario. Decades of relationships between us and them have created this. Because when words don't match actions, when promises are broken, when inertia is the norm, when leadership is not clear or lacking, it means our relationships can be damaged and trust can be lost. This impacts our self-determination and our willingness to play in the game. And this impacts our health and human rights and sustains inequity. We'll need to continue to bridge these broken relationships, but more will have to come from the other sides. The 6th issue identified in the Commission is artificial intelligence. And artificial intelligence has the potential to bridge the gap in innovation in Indigenous-led models of care by achieving systems change, clinical outcomes through integrated healthcare systems and through digital transformation of Indigenous healthcare. But if these same systems are not designed with inclusivity and equity in mind, they may exacerbate existing inequalities faced by our peoples. And if AI is not deployed or if AI is deployed by external entities without proper consultation or consent, these can undermine Indigenous sovereignty and self-determination. AI also has risks such as cultural misappropriation or misrepresentation. During the recent Yes campaign, we saw the rise of AI in generating so-called Aboriginal people to sprout the No campaign, funded largely by right-wing think tanks, individuals and corporations in this country. The final issue I want to talk to is political determinants that impact our people's health and human rights. But first, a national example of how this plays out. It's the story of syphilis. In 2010, a small group of us published Now might be about the right time to eliminate syphilis from Aboriginal and Torres Strait Islander communities. Ironically, around the same time an outbreak of syphilis was occurring in a remote community in a jurisdiction where the political party of the day had determined it would be better not to have public health services rolled out across the state and had them disbanded, resulting in now what we have as an ongoing syphilis outbreak in remote Australia. It's been the case since 2010. Almost 6,000 cases among Aboriginal people, mostly in remote communities, arose. This is a result of political decisions. This plays into trust, this plays into sexual and reproductive health. The other example I want to talk about was discussed here yesterday is the Global Alliance of Governments, the criminalisation of drug use with the so-called war on drugs, which has resulted in my people or Indigenous peoples all over the world being over-policed, experiencing higher rates of arrest, appearing in fatal overdoses data, having higher prosecution and incarceration rates for drug use than any other identifiable population. It has also resulted in higher HIV and hepatitis rates attributable to drug use among Indigenous peoples. This overt and intrusive global policy, the so-called war on drugs policy, has never been a war on the root causes of drug use. It's always been a war on the people using drugs. And until it is a war on the conditions which create the issue, it will continue to be a facade of action for political gain at the cost of people who need health interventions and not criminalisation. Finally, there are a few other things I wanted to raise that are not mentioned in the report, or some of them are. The ongoing impact of war and displacement of people around the globe resonates with us as we witness war such as what is occurring in Palestine now. It is a stark reminder of what might have occurred here in the frontier wars among our ancestors. I also want to mention briefly throughout the report, it notes the importance of decolonising approaches. However, when decolonising approaches is mentioned, it's always linked to lower middle income countries. It's an omission and it's an error, because without decolonising strategies in higher and middle income countries such as this one, it renders our disparities as invisible. Another issue I wanted to highlight is the intergenerational trauma created by colonisation. And if we think it's over, think again. One of the greatest challenges we'll have to think about into the future is the trauma right now being caused by having so many of our kids in out-of-home care settings or in state care. 44% of our kids are in out-of-home care now are First Nations children. We need to ask what services are missing now, why is this the case in the first instance, and then ask ourselves, are we going to be prepared for this into the future? As a nation, it'll be one of our greatest challenges in that we will need to think about major interventions to disrupt the out-of-home care system directly to prison pipeline. It is health and it is human rights, which segues into my final point. We have all the science in this world that we need, and I'm confident we can generate more. This slide here shows Hep C notifications among my people, even in the context of free, highly available direct-acting agents that can cure hepatitis C. They've been available in this country since 2016 and even during the COVID-19 pandemic. But what we don't have is equal access to it. And more so, the bigger problem is with implementation of these scientific advances. Timeliness, potency, multi-level, synergistic and community-led. Thanks for your time today, and best regards to the authors of this report. It's a compelling read if you haven't read it, and I wish you luck in progressing health and human rights in everything you do into the future. Thank you.
Thank you, James, for a stunning talk. I don't think anyone else could have captured that much information and with that much impact on a terrible situation that still exists in this country. So that was just brilliant. My name's Professor Sharon Lewin. I'm the Director of the Doherty Institute here in Melbourne and also the President of the International AIDS Society, and I am thrilled to be the co-chair of this event together with my colleague and friend Adiba Kamarul-Zaman. As Adiba mentioned earlier, she was President at the time of this commission. I have, however, been involved with other Lancet commissions through the IAS. Issues such as pandemic preparedness or integration of HIV into general systems, for example. And these commissions can be very, very powerful. They summarise an immense amount of ideas, work and evidence, and they try and translate it into action. So I think, as we've heard already in the first half of this session, how much work there still is to do around health and human rights. So we have a fantastic panel here. I'm going to give a brief introduction because time is short, and unfortunately we won't be able to have a Q&A session, but we will be able to hear for some other perspectives from our panel. So, introductions. I'd like to start with, and I've just lost my paper and I want to get it right. And okay. I'd like to start with Rajat Khosla. Rajat is the Director of the United Nations University International Institute for Global Health. He works on global health and inequalities, and he's got an extensive experience in this area as the Senior Director for Research, Advocacy and Policy at Amnesty International. He's also worked for the World Health Organization and is an adjunct research professor at the University of Southern California. My other panellists here, and I've got this out of order, is Associate Professor Rhys Jones. Rhys is a public health physician and Associate Professor in Maori Health at the University of Auckland in Aotearoa, New Zealand. He is a passionate advocate for health equity, Indigenous rights and also climate justice, and was a founding co-convener of Aotearoa, the New Zealand Climate and Health Council, and co-director of Climate Health Aotearoa, a national climate change and health research network. And finally, Professor Paparangi Reid. Paparangi is Deputy Dean Maori and Head of Department at the University of Auckland. She's also a public health physician and a graduate of the University of Auckland and is known for her long-standing work holding governments to account for inequalities, especially in health outcomes for Maori and other Indigenous people. So I'm going to speak to each of our panellists, Rajat, Rhys and Paparangi, and ask them to comment on the impact of this report in their own areas of expertise. I'd like them each to tell us what the most valuable contribution of the Commission is to them and its recommendations, really getting at the issue of what does this high-level, multi-page, multi-reference report ultimately mean in a local context. And then I'll ask them a couple of questions related to their own areas of expertise. So Rajat, we'll start with you. What do you think was the most valuable contribution of the Commission and its recommendations to you?
Thank you very much, and a great pleasure and honor to be with you all today and to reflect on some of these things. And I have to say, there was extraordinary remarks that we have heard already. In terms of the significance of this report and its recommendation, I still remember discussing this with Adiba and a few friends on the panel a while back, why this report matters so much. And I think the first and foremost thing is that because nobody else is talking about these issues. Quite frankly, we are not having these conversations on health and human rights in global health policy spaces in a manner in which we should be having. There is a systematic deprioritization of agenda that we have seen over the last several years and decades, and it was fascinating, the community forum and some of the examples that we heard just before this panel discussion, those are not having a reflection in the ways that they should be having. So the first and foremost reason for me, the significance of this report is that we are actually having this conversation, that we have a cataloging, and it's not a story of nihilism. It's not a story only to portray the desolation that one can imagine, but it is a story that this report is telling that things can be done differently and things have been done differently in different domains that the reports have talked about. But it is also a reality that in the 75th year of the Universal Declaration of Human Rights, and 30 years almost after Jonathan Mann set up the FXB Center on Health and Human Rights at Harvard, we are in a challenging space. We are in a space at which I think many have started asking the questions, are human rights a relevant framework? And I can say it rather provocatively, who cares? And if you look at what's happening in the world around us, I think it's a serious enough question. Are those in the seats of power really paying attention to the kind of human rights challenges and discourses that we are talking about, and are they being paid attention to? Sadly enough, the short answer is probably not. The other thing, which I thought this report quite fundamentally drives home the point, is that the human rights enterprise is largely state-centered. We are very much looking at, the Hobbesian theory, and Lucy very nicely talked about the duty-responsibility framework, that I have a right and the state has the duty, is state-based, state-focused. But if you look at the kind of geopolitical, geoeconomic shifts that have happened over the last several years, you feel that there is almost a disentanglement between the state's willingness to do what it is required to do and the state's ability to do that. And that has to be taken seriously, because what we are looking at is a rapid rise of other powerful actors within global policymaking and definitely within global health. And if you, in that context, try to look at the role of private actors, and not just production of countermeasures, vaccines, immunizations, medicines, but in the complexity of private actors that are now in the space of global health, you find that there is the willingness of state is often disconnected from the ability of state to do what it is required to do. And two final points in terms of the significance of this report and the kind of points that it makes, and which I will try and build it later in our conversation. One is about the challenge that our institutions are facing in terms of upholding the framework that we are talking about, the framework of health and human rights. We have had a remarkable plethora of developments in terms of instruments that have happened over the last several decades. But if you look at it from an implementation perspective, you find that it is slim pickings. And this goes across different health domains that we can talk about. You can look at it in terms of the statistic that Adiba was citing, whether it is criminalization and state use of punitive powers on what is happening, but also in terms of what is happening in terms of enforceability of human rights standards when it comes to health in the different settings that are happening. And then just a final point in terms of the significance of the report for me is the emphasis that it has brought into the role of health workers themselves. We often have an imagination that this is happening elsewhere, that this is somebody else's problem to solve. The role of healthcare workers as a fundamental driver to how we not only understand health as a human right, but we enforce health as a human right, has something that, for me, the report brings out quite remarkably. And bringing that framework of responsibility for healthcare workers in different contexts that they work in is rather profound. There is a lot more to be said in different combinations of it, but I'll leave it there and hope to come back.
Great, thank you very much. Some fantastic insights. We might move to Rhys, who will also reflect on what you think is the most valuable contribution of the Commission in your particular context.
Kia ora Sharon, kia ora tātou. Just once again like to pay my respects to the people of this land and to Indigenous peoples everywhere. And to everyone here, kia ora tātou. I would like to just pick up on Rajat's point there that I think the implications for health professionals are one of the key things that I would see out of this report, and this idea that we should be centring human rights in all our work as health professionals. And in particular, I think that really shapes what we see as the role of a health professional, what we should expect from health and medical education, really to, fundamentally reimagine what our role is. And I think that has huge implications for all of us. One thing I see in particular there is the call for us to speak out against human rights violations, wherever they may be happening. And I think we've heard some great examples of, I shouldn't say great, some really powerful examples of that today in terms of the genocide and other things that are going on in various places around the world. And it's been really shocking for a lot of us to see many of our health professional organisations being, if not silent, then pretty tepid about our responses to those violations of human rights. And so I think that one of the key things that I think this report does is make it clear that that is part of our role, and we shouldn't revile from that. And I think that, I guess another key point that I would make about what the report adds is that it's about the health field and health professionals having common cause with many other sectors and many other movements. I think that's a key part of what we need to do as health professionals, whether that be anti-racism, climate justice, gender rights, whatever movement. I think we naturally have a lot of common cause in terms of upholding human rights in all those spaces. When you think about it, actually we have a common enemy, the white supremacist, capitalist, colonial patriarchy, and which is actually responsible for the degradation of human rights that we've heard about this afternoon. And I think that by operating not in a silo within health professions, that we can then have much greater impact on human rights much more broadly. I'll leave it at that for now.
Thank you. Paparangi, can we hear from you about the most valuable contribution you think has come from this commission?
Kia ora, and I'd like to also, like Reese, acknowledge the guardianship of this unceded territory and the people who have welcomed us onto their lands and waterways this week. Tēnā koutou. I think the most important thing for me that the report brought up is, well, I remember a few decades ago where we couldn't even say the word racism in our academic practice, and yet here we are, in a very powerful way, talking about racism, talking about its impact on health, but also on outcomes that are broader than health, and putting it into a human rights framework. So I think that's the first bit of celebration I'd like to do, is focus on that. I also think it doesn't go far enough. I want to pick up on something James said. It doesn't go far enough in really recognising it as, it talks about colonisation, and there's a little bit of a focus on victims. There's a victim focus, and there's not enough focus on perpetrators. There is the work on reparations, which sounds like it has great potential to me, but really we still have to talk about, and we're looking in the wrong direction in a way. We're not looking at the systems that are causing, we're looking at the systems that are impacted by impacted by the inequities, rather than focus on, as Reece said, the patriarchy and the white supremacist establishment. And colonisation does establish those domains of power. So I think there could be a little bit more on that. I love the focus on reparation, but in our experience, sometimes reparations is often done in a minuscule monetary amount, and not enough is given recognition of things like land back, territories back, and really re-establishment of the Indigenous ways of engaging with place, physically and spiritually. So, one, I love it, that it does bring things into our conversation, but two, I worry that it focuses too much on where the impact is rather than where the cause is coming from, and I hope we can spend more time talking about cause.
These are great points, and we actually have very limited time left. And one of the main focuses of the Commission, I think you make some good points about the underlying cause, but they focus very much on action and solutions. And I thought Lorraine Dean said it well, with structural problems need structural solutions. So maybe if I could get each of you to reflect on some priorities in the domains that you influence most amongst the three of you, the higher education sector, training our next generation of health professionals, what sort of structural change or solutions might be achievable in those domains of education? And we'll just have a brief comment from each of you, because I'm sorry, but we're close to finishing up time, I'm afraid.
I'll try and do it as quickly as possible. But
and you have a flight to catch, Rajat.
And I do have a flight to catch. But importantly, I don't think we can talk about that without actually unpacking slightly the kind of the emphasis on context and where the problem lies from. Much has been said in the last day and a half now about the context that we are living in, the poly-crisis or perma-crisis, as many describe it as. Ilona Kickbush yesterday in the opening segment said it wonderfully when she broke down, what's happening to trust and the idea of trust amongst us and what needed to happen in that regard. So I think if you look at it and come back from that perspective, if that is the context of a world in polycrisis, breakdown of trust in institutions, in people, in each other, and just to layer it one more level is the issues in terms of what is happening in terms of crackdown on civic space, on voice of people. In countries after countries, we are finding that there is a stifling of dissent is what is happening, that there is no space to express the kind of opinions that are needed to challenge the status quo that we are. So what can we do from the education sector, and what can we do from other sectors that there are? The first is about reclaiming the narrative and the space that we are operating in, and the issues around coloniality, addressing power asymmetries that tend to determine how these issues are manifesting themselves goes to the root of it. How do we address those power asymmetries through the evidence generation work, through the academic work, through the training programs that we do? And quite honestly, we are not doing enough. We are mostly talking about these issues from a rhetorical perspective. When you look at training curricula, educational programs, it is at best an option that might be available. It is nothing more than that in most cases. The second is the issue that somebody said it remarkably well early on. These issues require resources. We do need investment. Where is the money to do the work? We are talking about a very deep, complex problem, but if you look at investments in social justice issues, in human rights issues, in context of global policy, there is very little happening, and there is very little happening to incentivize educational programs that will train medical healthcare professionals or public health professionals onto these issues. The third is a transdisciplinary framework is what we require. This is not just a problem that we can fix from the legal and policy domains itself. It has to be a transdisciplinary issue, and we have seen successes, right? When we combine the human rights narrative with a justice-oriented narrative, when we bring the values from different disciplines to weigh into it. And then just a final thing is what I think, Reese, you already said, is stand up for human rights. For everyone, everywhere, not just when it affects you.
Reese, some reflections from you on the local solutions potentially through your roles in education?
Yeah, I think I talked earlier about the need to kind of fundamentally reimagine the role of health professionals, and I think that means we need to fundamentally reimagine medical and health professional education. And what that means, I think, is that rather than starting from a point of, scientific disciplines feeding into clinical knowledge and care, we actually need people to understand those big systems that shape our world, natural systems, but also our social, cultural, political, economic systems. And so one of the key attributes, I think, is what we often talk about in Indigenous health is around critical consciousness. So having an understanding of those systems of power and oppression and how they lead to violations of human rights. And also, really importantly, positioning ourselves within those broader systems and within the relationships with other people, but also with our more than human relations. And I think that's another point I'd make, is that rather than a specific human rights focus, I think we do need to be thinking much more broadly in terms of multi-species justice and the rights of nature, the rights of all beings. And that's something that, as part of health professional education, certainly in terms of planetary health, that we need to be getting across that broader perspective as well, not just human rights. So, yeah, those are some of the I think the implications for health professional education. Yeah.
And Paparinga, we might end with you and your comments, and I think particularly in light of James's presentation as well, how you think the recommendations could be strengthened by applying Indigenous notions of rights and health.
Recently, I've been talking to some of our students who want more Indigenous health context in their training, and I find there's a tension in them wanting more knowledge and understanding of Indigenous issues and Indigenous ways of thinking and being. But I also think they need a whole lot of activism. And I think that we need health professionals to learn how to be activists and work on these issues as activists in collaboration with communities.
Well, I think that's a fantastic note to end on, because all of us can be activists. When you think about structural problems and structural solutions, it can get a bit overwhelming, but every person can be an activist, health worker or not. I'd like to thank the co-chairs of the Commission, Adiba Kamarul-Zaman and Chris Beyer, for putting together, and all the commissioners. I also want to make a quick plug for the IAS, holding our international meeting in Munich, 24th to the 27th of July, specifically in Munich to focus on the major challenges currently happening in Eastern Europe and the impacts of war and migration, particularly on Ukraine. Big focus on health and human rights, as always in every HIV conference. So we'd love to welcome you to Munich in the end of July. And thanks again to this really interesting session. Thanks to all our speakers.